I'll just be honest here at the beginning. This is probably a highly biased assessment of the published literature. But this is the kind of outline of my presentation, which is I'm going to look at some lessons from the past. So I'm going to kind of go back quite a ways to look at what we learned in 2 points of time. One is the support study or trial, and the second was a large literature review done by the RAND Corporation on authorization request of the U.S. Congress. Then I'm going to look at a summary of two more recent review articles and then look at what else we know, because there's other stuff out there that is published but not in peer-reviewed. Look a little bit at what new research is underway and what research may we still need.
The presentation.
Oh, I'm sorry, thank you. Didn't look at the screen. How many are familiar with the support? About half of you, okay. So this was a study funded by the Robert Wood Johnson Foundation. I believe it cost like $27 million. The full name was the Study to Understand Prognosis and Preferences for Outcomes and Risk of Treatment. This was a multi-site study. One of the sites was actually in Wisconsin at a health organization similar to Gunderson called Marshfield Clinic and St. Joseph's Hospital in the middle of Wisconsin. It was a randomized controlled trial to test to see if improved information for the treating physician about the ICU patient's preferences and prognosis would improve quality of end-of-life care. Other sites, the sites were very different. So I think the Wisconsin site was kind of considered a more rural site. There was a site in Los Angeles. So they were very different kinds of settings. They did a baseline study where in all of the 5 sites to see what care looked like before they began. Then they randomized patients into intervention or control at each site and measured their outcomes. Now, according to Joanne Lind, the PI, the assumption as they looked at what they could do was that outcomes were driven by baseline characteristics. So the outcome of treatment were driven by the patient's disease and their physiology. The support researchers believe that this was an inadequate analysis of how outcomes occurred, and they felt that the outcomes were also influenced by not just baseline characteristics, but by the decision-making about the treatment. Seems reasonable. Actually, can't imagine why people wouldn't have thought about that anyway. And the goal of the support was to develop an intervention to improve decision-making. Sound familiar? We're still trying to do this. So the idea was if they could improve understanding of prognosis, and if they could improve understanding of the current and past preferences of the patient, and if they could assist the patient and family so they could make choices that aligned with patient's goals, and then to achieve these greater understanding of prognosis and the greater understanding of patient preferences, there was an intervention nurse who was working in the ICU and assessing prognosis using basically a formula, and also talking with the patient family, looking for advance directives, and feeding this information to the treating ICU physician. And so the idea is if this treating physician had better understanding of the prognosis and a better understanding of the patient's preferences, decisions would improve, care would improve, and the outcomes would change. After spending $26 million and randomizing all these patients, the outcomes were very clear. There was absolutely no improvement over baseline or between the intervention and control. And this was just shocking that that improved information and decision-making wouldn't improve outcomes. I consider this as one of the most important medicine research failures in the 90s because we learned a lot from this study. One thing we learned in particular is how much pain patients were suffering that was being unaddressed in the ICU. It was disturbing, I think is the right word. But this study really helped us, I think, learn why this failed and gave us some insight how we might be successful. And what I want to share with you are direct quotes from Joanne Lynn, the PI's analysis of why this was a failure and what might make a difference in being successful. So she says in this article, I have the reference on the next slide if you want to look at it, improving patient-physician communication cannot ameliorate shortcomings in care. Improvement requires restructuring the entire environment. Education alone will not work. A more systematic, far-reaching, and deeply seated plan to restructure the hospital environment is needed. She actually used an analogy that went something like this. When a plane comes in to land at an airport, it follows a glide path. And the glide path is a predictable way to get to the ground safely. Practice consists of glide paths, routines of care, which are predictable, they're comfortable, and in the ICU, the glide paths are what they are, and some more additional information doesn't really change that landing pathway. And families and physicians and other health professionals are actually comforted by staying on the glide path regardless of what it looks like. We actually have to redesign the glide path in order to change where the plane lands. So how can we think about such change, Joanne goes on to write? Certainly merely signing advanced directives would not accomplish much. I think we all accept that as a kind of very basic principle in respecting choices. And neither would encouraging patients one by one to demand change. So community engagement and social engagement on the community level is probably not going to be enough either. Instead, healthcare, we should think about this as a public health issue, and how can we reorganize to serve seriously ill people best. Reformers might do better to adopt a model of continuous quality improvement at the system level. Does this sound familiar to you? I hope it does. This reaffirmed my experience at Gunderson. This is what she learned and is what I saw in creating and respecting choices. Now, there was a big review of the literature by the RAND Corporation. It was authorized by the U.S. Congress. They looked at 365 published peer-reviewed articles that were published between 1990 and 2007. Here's one of the central conclusions that they found in looking at all of this literature. So these were the prominent, well-recognized articles of intervention to improve care through some type of patient engagement or planning. Simple component consumer education interventions designed to increase knowledge of or completion of advanced directives were mostly unsuccessful or were only modestly successful. Interventions were more successful when severely ill patients were targeted, when multi-component longitudinal approaches were used, that is, interventions using educational materials combined with repeated treatment preference discussions during clinical encounters over time with enhanced accessibility of the documentation of the patient wishes were needed. This is what Kelly described. Okay? Only multifaceted interventions increase the frequency of patient-initiated discussion with patients. So this is after looking at all kinds of efforts and attempts. This is what the RAND review found. Now, we've had two more recent summaries, looking at more recent articles. The first was actually the background review that was done for the European trial called the ACTION trial. In this case, they reviewed at 113 articles. It covers a more recent period of time, 2000 to 2012, you'll see. And you can see the studies that were included were the effects of advanced care planning. They looked at qualitative studies, reported patient and utilization outcomes, and included intervention and observational studies with control groups. Here's the conclusions. Advanced directives were associated with reduced frequency of feeding tubes, but not other medical care or symptom burden, quality of life, and so forth. And it says they concluded it seems unlikely that advanced directive documents, have a substantial impact on patient-centered end-of-life care and satisfaction of care. They also concluded complex ACP interventions were found to result in an increased frequency of out-of-hospital and out-of-ICU care and increased compliance with patients' end-of-life wishes and satisfaction of care. We did not find clear results with respect to medical care except for a tendency towards increased use of hospice and palliative care. And in a small majority of studies, psychosocial measures were positively affected by advanced care planning. So again, after the more recent review of 113 articles, complex ACP interventions seem to have the kind of impact that we're striving for. There was another review which looked specifically at respecting choices interventions and tests. And this group identified 18 articles that looked at 16 different studies that reported outcomes of the RC and derivative models. Now, the derivative models here are like the honoring choices, so I don't know if they're really derivative or not. 9 were randomized controlled trials, 6 were observational, 1 was a pre-po test. So that's what they looked at. What they found is the respecting choices intervention showed an increase in completion of advanced directives or PULSE forms, a greater patient surrogate concurrence in making choices in specific situations, and you could now add Dr. Lyon's most recent study published in the Journal of Pediatrics for adolescents, and the long-term outcomes regarding consistency of preferences being honored and its effect on overall utilization. So they found that RC increases congruence between patient and surrogates' understanding of patient's value. Now, this is not concurrence with care. This is concurrence of understanding between surrogates and what the patients want. Now, that might seem like, well, is that so important? I can tell you that before the Next Step study done by Karen Kirchhoff, there were no studies that showed any improvements of concurrence between surrogates and patients' understanding. None. There were many tried. Respecting Choices was the first study to show that it could improve this concurrence. There was an increase in prevalence of documents, and they said, but we still need more evidence that Respecting Choices actually improves end-of-life care and leads to congruence between treatment and preferences. And on some level, we could always conclude that. We probably always need more evidence or would like more evidence. This review, however, in my perspective, had some really important flaws. What the authors failed to recognize is that most of the research that used Respecting Choices only test the facilitation part of Respecting Choices. Most of the studies that have been done, and I'm not being critical of that, test whether congruence can be improved by doing this facilitation, next steps, last steps, and so forth. It doesn't test the whole model. There's really only been 3 studies that in some way test the whole model of Respecting Choices. All of you understand there's the 4 elements. Most studies only test one part of one element. A few studies that they actually missed a few studies, and I can't criticize them. They were hard to find. I only know them because I was aware that they were being done. But if you read the literature, you probably wouldn't know that. They incorrectly described the design and outcomes in some of the studies, And they incorrectly ascribed stages of planning in some studies, and they completely excluded any kind of practical clinical trials reported in white papers, and I'm going to come to those in a bit. There's only really 3 studies that I can see that to some extent really use the whole model. The LADS 1 and 2 studies in lacrosse, the dithering study in Australia, and you wouldn't know that the dithering study used the whole model, but because I worked with that team and I understand the intervention, I know that they did system redesign, I know the materials that they had. All of those pieces were in place before the study was done. And then the intermittent study in Germany really did a regional redesign, but they only measured some small outcomes. All of these studies did show an increase in written plans. Studies 1 and 2 showed an increase in wishes known and honored, and a decrease in utilization of hospital services. And study 2 showed a strong positive emotional impact on family members involving in the planning process. So where we actually have 3 studies that used more nearly the complete implementation of respecting choices, the outcomes that we want have been shown to occur. The authors in this review said more research is needed, especially comparative effectiveness trials, and they're absolutely right about that. And evaluations of use of RC, we need to know whether preferences are being honored, lower utilization of health resources occurred, and positive emotional outcomes are appreciated. Now, what else do we know? Because there's more than the published peer review literature out there. And 2 of the things I want to point to come from Australia. First of all, at the Austin Medical Center, besides the randomized control trial, they did a kind of qualitative analysis of their implementation. And so what they showed is baseline data in 2001, 10% of inpatients had poorly created care plans, and 14 had a completed power of attorney for healthcare. After full implementation of respecting choices in 2003, looking at 360 inpatients, which were followed, 47% of them were introduced to advanced care planning. 70% of these expressed preferences recorded in their medical records, with 20% completing a formal document, and of those who died, 95% had their preferences honored. So this is a short-term kind of measurement, and they showed some really good outcomes. The second, it also comes from Australia, and it was involving nursing homes. There were 16 aged care facilities, is what they call them in Australia, and they implemented facilitator training and other system changes in 16 nursing homes over 1 year, and then they stopped and measured. So what they had at this point is of all the residents in these 16 aged care facilities, about half of them had been approached and done planning. First of all, they found that residents and families who were approached were willing to have planning conversations in most of the cases. 51% of the residents during the first year implementation were introduced to the program, so that's the ones who were satisfied. 52% of those introduced completed a plan. 90% of the plans requested a palliative approach to care. This is something they hadn't known before. And of the 161 residents who died, either with plans or not plans, 58% were introduced to advanced care planning. 89 of them had document preferences. 100% of the known preferences were honored. I actually challenged this. Dr. Sylvester said, that's right, 100% were honored. I said, how do you reach 100% when you need to have all these systems in place for things like doctor's orders? He said, what do you mean? I said, well, if a patient has a preference in a facility like this, they need to have a doctor's order expressing what that preference is, so the staff needs to know. No. He said, not in Australia. I said, they don't? He said, no. If you're living in your home and you have a preference, your preference is what follows. Everyone just follows your preference because that's your home. You don't need a medical order. You don't need a doctor's approval. I thought, that's kind of seems to make sense to me. So that's how they got 100%. The patient's preferences simply directed care. 100% had preferences honored, and 88 had died in the residential facility. Residents who died but did not have their plan in place were 2.5 times more likely to die in the hospital. This showed a major change in the prevalence of planning, wishes being followed, and reduction of hospital utilization. So this is not a peer-reviewed article, but this is a practical clinical trial, which I find very helpful and insightful. The economic impact analysis and end-of-life planning for nursing home residents, Project CARE, was a project done in Singapore. It used a respecting choices model. It was implemented in 7 nursing homes to provide advanced care planning using last steps and a palliative care for the residents at risk of dying with 1 year. The outcome, residents in Project CARE had subsequently lower cost of care in the last 3 months of life because of fewer hospital admissions and shorter lengths of stay in the hospital. Now, this was a multimodal intervention that included advanced care planning, palliative care training for the residential staff, and access to specialty palliative consults. They showed a dramatic change in how care was delivered, where it was delivered, and the quality of the outcome. Very different than the support study, but it was multimodal. So what research is starting or coming? So there's a big PCORI study being done at Duke by Kimberly Johnson, palliative care specialist, and in this study we're having a comparative effectiveness trial looking at kind of a chronic first steps discussion versus a self-directed 5 wishes completion. And the study is being designed so that intentionally over half of the 800 subjects will be African American. So we're going to really get, I think, some good documentation now about whether a self-directed approach versus a facilitated approach have dramatically different outcomes, similar outcomes, or something like that.
Can I just add to that, Bud, that half of the facilitators are African American and half are Caucasian, and so they're also testing the effectiveness of having someone similar to you facilitating the conversation.
So Linda Briggs, and I think Sandy will be taking over, is the kind of respecting choices expertise to make sure the intervention is delivered in accordance with respecting choices standards. Dr. Shanker at the University of Pittsburgh has a proposal which has been evaluated and is expected to be funded. In this project, there's going to be a comparative effectiveness trial of 2 formats of advanced care planning, respecting choices, first steps, chronic, and prepare for your care. This study is going to look at cancer patients who have serious cancer, and this study is expected to begin sometime early next year. Dr. Lyons has a study focused of kind of replicating some of her work, but in this case with the Spanish-speaking teen population. And then Alexa Troche has a study which is up for review. I believe that's been scored, right? And yeah, so it looks positive for funding. This will evaluate, if it's funded, a systems-based approach to advanced care planning for a population of high-risk older adults to ensure that quality decisions take place, leading to a pulse document that are completed and available. So what's different about this is a home-based population who have serious illness and have a palliative care kind of coordination of care. So these are just some. There are actually 10 active studies right now. What our research is needed? First, those of us at Respecting Choices Office leadership think we need to do a large practical clinical trial. We need to test the whole intervention in a fairly rapid pace and really measure the total outcomes. We need to evaluate how to better determine the true values and goals of the individual. Are we actually capturing not just preferences, but the actual preferences of patients? We need to study how we better achieve a cultural change so person care is the norm. And then finally, does RC ACP facilitation have more benefits than just creating an effective plan or a document? There are kind of anecdotal stories from patients and that we receive that advanced care planning helps create capacity in relationships to have better ongoing discussions about what matters most. So what if a next steps conversation not just creates a plan, but creates capacity between this family to continue to talk about what matters most, so as things change, the family actually is doing their own planning on an ongoing basis. That would be a powerful outcome. Does it deepen interpersonal relationships and help create a better sense of well-being? Dr. Lyons' recent publication indicates that there is this positive emotional effect that improves health. I think we need to study that more deeply. And does it provide an opportunity of individuals and their families to rehearse complex medical decisions so that when they are faced with those decisions, they have actually practiced decision-making to a sufficient degree. So when we want people to learn CPR, we don't take them in the classroom and have them think about it. We have them practice it, and they have to show competence. What if facilitated discussions are a practice session for decision-making, and its real power is to enable people to know how to make decisions when they come up, not completing the document. Maybe that's the power that we've been missing. All right. Those are my thoughts on what needs to be studied.
Thank you. I just want to say that we need to bottle everything that's in your brain, capture it, and disseminate it to everybody here and all those that are interested. I think we have time for 1 or 2 questions.
So Jessica from Washington.
Yes, I recognize you.
Good. Thank you for that presentation. It was really helpful. I'm curious about opportunity. So looking at the research that's needed, how do organizations get involved with this? Thinking about us as a convener, how can we guide our teams to get going on helping out in these areas? Because I think there's a lot of opportunity in Washington to answer some of these questions.
Sure. Well, talk to Sandy would be my quick, simple answer. With Linda taking a different role, Sandy is going to be really kind of leading our research efforts. Linda and I'm sure, will be still around. Carol will be involved. We have other researchers in the room. So, you know, Respecting Choices is really taking the stance. We don't think we should be conducting the research. We're too biased to directly do it. But we want to support the research because we want things to be evidence-based. If what we're doing isn't working, we want to improve what we're doing. We want to change what we're doing. We want to provide effective interventions for everyone so that the research benefits all patients, all health systems, all providers. So we'd like to partner with you, and so we do things like saying you should talk with this researcher. They'll help you. We can help you with some of the design and the intervention because we have some experience there. The biggest challenge, I think, for most of us is finding the sufficient funds to carry out the work. So to, Carrie's point, she hasn't measured out in the community. We were able in La Crosse to get, $100,000 to hire a research assistant to go out to nursing homes and collect data about deaths and what happens out there. So a lot of this is driven by funding and not by the lack of ideas.
And I would just echo that we're very interested in partnering, collaborating, assisting with research when it's appropriate, but we don't know about it if we aren't connecting and collaborating and talking about it. So really would like to have more of an open door policy around that. And if anybody's interested in setting up an appointment with me, check in with Katie at the registration desk and we can talk further. And then in the research interest group, there were lots of suggestions from individuals about what would help them, a possible advisory group for research or some sort of quarterly meeting with people doing like projects or research so that you could learn from each other. So reach out to me. And so let's give Bud a round of applause, and we'll convene there for our final plenary session.